CTSNet friends. My name's Joel Dunning and I'm delighted to bring you this very special AATS edition of the CTSNet podcast. We're going to talk to you all about the latest from the AATS, but that's not all. We've got journal and news scans and we've got some great videos. We've got news about a randomized controlled trial in albumin versus ringers. We've got some news from African circulator arrest surgery. We've got some amazing congenital videos and a really good 1-hour seminar in surgical aortic valve replacement that you can tune into. There's loads in this packed edition, so don't go away and let's get started with this CTSNet podcast. So, of course, the big news this week was the fantastic AATS meeting in Los Angeles. Congratulations to everybody at the AATS for doing such a brilliant meeting. I don't think the word COVID was mentioned once. Isn't it great that we can all meet together? The exhibition halls were packed. It was really thronging, really exciting, really interactive. And the other really great thing is that over 1,600 abstracts submitted this year. That's a record for the AATS. So congratulations. We really are back with a bang, and we really understand what it's like to have in-person meetings. So Yolanda Colson was the president this year. She gave her presidential address, and I didn't actually realize that she actually has a degree as well as medicine in engineering, and I think that was somehow reflected in some of the program. It was really diverse. They had such interesting different speakers. One of the keynote speakers was Judy Woodruff. She's the anchor for the PBS NewsHour on American TV, and she gave a great talk all about what news can we trust in an era of misinformation and disinformation. You know, it couldn't be more timely to have a discussion like that, which is absolutely fantastic. Another really good highlight keynote talk was by Siddhartha Mukherjee. He's a Pulitzer Prize winning author. He wrote the book The Emperor of All Maladies. Well, what is the Emperor of All Maladies? Well, it's cancer, of course. And he gave a fascinating look into the story of cancer. He's actually written a second book as well called The Song of the Cell, again about cancer and the future. And really, it is such an exciting future. The way we're going to fight and treat cancer, it's exploding with the targeted cell therapies, immunotherapies, personalized treatments. So two really great non-surgical talks there. There were others as well, actually. Gilda Barabino, president of the College of Engineering, gave a really interesting talk all about how we can address health disparities. And I thought that was really interesting. And then from our side of the pond, Tony Roux gave a keynote speech. He's such a wonderful person with over 30 years experience in thoracic surgery, in particular esophageal surgery. And the wonderful thing he shared about was his experience working in West Africa. It's absolutely horrifying to think that there's a huge number of young kids that get caustic soda burns. You may not know, but a way to make a little bit of money is to make soap out in Africa. And a lot of governments make caustic soda available so you can make soap. But it doesn't come with childproof tops and it looks like milk. So a child will take a big glug and that will cause a terrible esophageal burn that will cause permanent damage to the esophagus. And he told us all about addressing these terrible severe strictures. There was so much more at the AATS as well. There was a business summit. There was a really nice session I liked from Jennifer Lawton, basically sort of questioning, why aren't we all doing total arterial grafting? The evidence is out there, and saying basically, well, maybe it's due to our incentivization system. We all have to do Lima to LAD, and it's a mark of quality. And surely we should use a second or total arterial grafting as a marker of quality. Maybe that would drive change. I thought that was quite interesting. There were a load of masterclasses that were all given, and probably the standout one was maybe from the amazing Pat McCarthy. Again, he spent so many years looking into mitral repair. He gave a great masterclass, and not only on how to do it, but also how to teach people. And there was a person there, people that he had taught that could then sort of pass on his knowledge, which was great. And then I think probably the number one standout session for me was one run by Torsunt and Craig Smith. It was the management of iatrogenic emergencies. Yes, emergencies caused by us. It really was a look, and you could only look behind your fingers because it was kind of squeaky bum time. They addressed all those worst emergencies: posterior LV rupture after you've done a mitral replacement, myocardial ischemia after a Bentals. What are you going to do next? You causing an intraoperative type A dissection when you're doing an AVR or grafts or something. Catastrophic sternal re-entry and redo surgery. Emergency conversion after in robotic surgery. Iatrogenic VSD when you're doing a myectomy, and that horrible one, annular rupture, if you're doing a TAVR. So congratulations. I think I'd basically just like to ring you two every time I have one of those complications, but you certainly gave some great hints and tips on how to address all those emergencies. So in summary, congratulations AATS, absolutely wonderful meeting, well done. We're going to give some more shout outs and some more videos, hopefully. We've had our editors out there doing a few interviews and off the podium, so do look out on the CTSNet website for more content from the AATS. So we are profiling 3 journaling news scan items that stood out for us. So check out the website on JANS to check these out. The first one was quite interesting, I thought. Terumo are really famous for doing brilliant frozen elephant trunks. You've got a massive dilated aorta. You're going to chuck that frozen elephant trunk in an antegrade fashion, and then you'll do your head and neck vessels. But they've got a brand new aortic ThoracoFlo. So from below, if you're doing an abdominal aortic aneurysm, but it's dilated across the diaphragm, then they've now got a kind of retrograde sort of frozen elephant trunk. So you can put that up into the thoracic aorta, and then there's a big branch graft that you can then plumb in the rest of the abdominal vessels without doing a big thoracoabdominal incision, without circulatory arrest. So look really, really good. Randy Moore at the University of Calgary is the first person in the Americas to have performed this, and gives a really nice account. And the other really nice thing is this access for this patient was through the Health Canada Special Access Program for patients who are not suitable for off-the-shelf products. So a great little post there. Go check it out. The next thing that stood out for me was a really interesting article all about Zambia's first total arch replacement with circulatory arrest. So Gaurav Alawadi led a 6-person surgical team from Ann Arbor who went to Lusaka in Zambia. He paired up with Chelesi Mutema, who's chief of thoracic surgery there at the National Heart Hospital. And the patient that they operated on was a 72-year-old who had a potentially fatal aortic dissection with an 8-centimeter arch going into the carotids. So they were faced with this, and the only solution is hypothermic circulatory arrest. Now, it's a lot more difficult than you'd think to just go and do these things in Africa. There's so much things they don't have. So the surgical team didn't have a branched aortic graft, so they couldn't give the head and neck antegrade plegia. They had to give 2 episodes of hypothermic circulatory arrest, as they only had straight grafts. They had to fashion some stuff magically. Thankfully, it went really, really well, and the patient did fantastically. They also document another really interesting case, a 49-year-old with a double valve replacement who they were doing. They ran out of cardioplegia kits, so they couldn't deliver cardioplegia. So how did they do it? Well, they thought out of the box. They got together as a team, and they used cross-current fibrillation. They used fibrillatory arrest to repair a mitral. And secondly, repairing the tricuspid valve, they didn't have a ring, so they had to make a ring out of felt. Well, congratulations. That really is thinking on your feet. They've all done really well, and it's wonderful to see. CTSNet really want to support missions. We think it's going to be a new thing we want to support far more heavily over the next 5 years, because it's so important. I've been on 5 missions myself, and when I leave my own institution, if I'm not doing an operation, someone else does the operation for that patient. But when you go out to the developing world, if you don't do the operation, nobody's going to do the operation. That person will not survive. So it really does make a difference. And when you come back to your institution, problems that you have in your own Western world just don't seem quite as big when you actually run out of medications, don't have tube grafts, don't have cardioplegia. So congratulations to that team and everybody doing missions out in the third world. The next news item that jumped out at me was a really big randomized controlled trial. This was the Albix trial run by Eero Pessonen from Finland, and it randomized 1,386 patients having heart surgery to either using 4% albumin or Ringer's lactate for priming your bypass surgery, your bypass circuit, and volume replacement. So you either use one or the other in a random fashion. Remember, completely randomized, and so all the rest of the surgical techniques were exactly the same, and the differences were really quite big. So they employed a bleeding grade, and in the severe bleeding grade it was 10% in the albumin group versus only 3% in the Ringer's group. 45% of the albumin group got red blood cells versus 31% in the Ringer's group. 33% got platelets in the albumin group, only 20% in the Ringer's group. And, this stuck out to me the most, restenotomy in 5% of the albumin group and only 1.9% in the Ringer's group. That's big differences in what you use for your volume replacement and your bypass prime. So I think that was really impressive, really important findings there. Go check that out. It's the Annals of Thoracic Surgery this month. So that's our Jan's editions and something from the AATS. And now I'd like to hand you over to CTSNet to tell you more about what you can find on our website.
Take advantage of the features on your profile page to tell the CTSNet community more about yourself. Head to ctsnet.org/user to update your background, place of work, and contact information. When you're done, head to the Profiles page to stay connected with colleagues and learn more about your fellow CTSNet members.
We've chosen 3 fabulous videos for you this week, so do please check them out on CTSNet. The first one I think is really interesting if you've got any interest in ECMO. This is a decannulation from Veno-Venous ECMO, which is just great to see if you don't do it all the time, or you might be coming to do your first. There's some really nice techniques. But the special thing here is that it was done in an awake patient. So this is by Ryan Azarafi from the University of Florida and Giles Peak. And the patient was really interesting. It was a 29-year-old man who had congenital hyperplastic right heart, pulmonary hypertension, dextrocardia, and he'd been in hospital several months before he finally got his heart-lung transplantation. The post-operative period was complicated by coagulopathy and graft dysfunction, so he went on to VV ECMO, he went to renal failure, etc., etc. The standard fare for heart-lung transplantation. But anyway, he did quite well. So they extubated him on ECMOs to facilitate pulmonary rehabilitation, so he could sit up, he could talk, and he could interact, and he could cough, which is really, really good. And then on day 22 of ECMO, he was doing really, really well, and he was satisfying all the criteria for decannulation. And this is where the video starts. They document really nicely the removal of the femoral cannula, followed by the right internal jugular cannula. And the things that stood out for me from this video was the really careful and meticulous way they emptied all the blood from the circuit to minimize blood loss. And then, amazingly, they literally just did a purse string around the cannula. They pulled the cannula and tied it, and they didn't press at all. And they said in the video, you don't need to press as long as no hematoma is forming, which is really great if you're doing it awake, so you're not having to sort of push, which could be really sore and painful for the patient. And it was amazing. They showed that in the video. So congratulations. That's a really fantastic and impressive video. And it was also the winner of the Residence Video Competition. So congratulations to Ryan Azarafi for that. Our second video is in tribute to James Tweddle. As many of you may know, he lost his battle with cancer on July the 1st, 2022, and was probably one of the greatest congenital heart surgeons in our community. In respect of this, Alan O'Donnell from the Cincinnati Children's Hospital has done an absolute blinder of a job of a series of videos in honour of James Tweddle. And this video, not just is it an amazing, beautiful video, but it has been so well put together. It's been annotated. There's really good stop and start, and shows you exactly what's going on and what did they do it on. Well, they chose the How I Do It by James Tweddle, the single ventricle palliation with Norwood Sano, Bidirectional Glen and Extracardiac Fontan. So it's a series of 3 videos. The video up this week is the stage 1 palliation. So in this video it shows the Norwoods with Sano, right ventricle to pulmonary artery conduit. And then stage 2, which is a different video, is the Bidirectional Glen. And then stage 3 later on is the Extracardiac Fontan. So it's really detailed. It's half an hour's long. So it's really great. And for myself, I never did congenital cardiac surgery, but I'm absolutely fascinated by this completely different branch of cardiac surgery, and this was so good for showing in really perfect detail the exact steps. It showed, first of all, opening the chest in this tiny child that was only a couple of days post-delivery, the suturing of a graft to the innominate artery, only 3.5 millimeters in diameter. Then they used that graft to commence cardiopulmonary bypass. They cooled the patient down to 20 degrees centigrade, and then they harvested a patch to fashion 2 patches. They show us in the video 2 patches. One patch is the patch aortoplasty, and the second one is to patch the branch PA confluence. So when they get down to 20 degrees centigrade, and this always freaks us as adult cardiac surgeons, they took the venous pipe out, they went into deep hypothermic circulatory arrest, and they opened the septum to make a common atrium by excising the whole atrial septum. They then put the cannula back in, and they divided the ductus, and then they went on to do the neo-aorta reconstruction. They then performed the Damascus Stansel procedure so that the coronary arteries were being really well perfused, and that was nicely shown. And then they do the second part of the neo-aortic reconstruction. Then they do the right ventricle to pulmonary artery conduit, the Sano procedure, and successfully weaned for cardiopulmonary bypass. So really beautiful job. Even if you're not an expert congenital surgeon, just watch it for the beauty of the operation and the fantastically edited video, and just for your own interest. It was really, really good. So well done. And then the final video we have for you this week is a really, really good middle of the bat, meaty surgical aortic valve replacement 1-hour seminar led by Vivek Rao of the Toronto General Hospital. He was the moderator. He was joined by William Brinkman, a cardiac surgeon from the Baylor Scott Hospital in Texas, Barbara Hamilton from the University of Michigan, Bo Yang from Michigan, and Sarah Palmer from Michigan, was at Michigan, now at Abbott Northwestern Hospital. So it was really, really good. It was sponsored, so we're very grateful to Medtronic for sponsoring this, and they highlighted the Avalus valve. They've just done a really big cohort study on the Avalus valve, looking at a cohort of over 1,000 patients, and a few standout things came from that. Firstly, the mortality of the patients was only 0.5%, so that's brilliant. 5 in 1,000 patients. That's really, really outstanding surgery from multiple centres in America and beyond. Well done. The STS risk score of note was 2%, so surgeons are smashing it, a quarter of the mortality of what should be predicted. The second thing was really good 5-year outcomes. There was a 97% freedom for reintervention from these tissue valves, and also interestingly, they said there was a 1.3% bleeding rate post-operatively, and it is an international study, and they thought that the reason for that bleeding is that there are a lot of centres across Europe that give 3 months of anticoagulation after an aortic valve replacement. Now, some of those patients will have atrial fibrillation, but some, that's routine in their practice. What do you think about that? Certainly, this panel felt that it is not necessary to give 3 months of anticoagulation when you're having a biological valve. Probably an area that we need to perform further studies in, isn't it, really? But certainly that is causing an increasing bleeding rate. You may argue that a bleeding rate is fixable and a stroke isn't, but really an interesting little discussion was had on this video. The other thing that really stood out for me was Bo Yang's absolutely immaculate description of his Y incision technique for aortic root enlargement. This, he says, he started in 2020 and it has been written up in the JTCVS. He makes a vertical incision between the non-coronary and the left coronary cusp, but unlike other incisions like the Menugian and NICS, where you go right down further more deeply, you may go into the basal ring or even into the anterior mitral leaflet. He cuts down, then goes across so that you don't cut into the mitral leaflet, which he says is safer and it's pretty easy. And he then just patches it, and he can really enlarge roots very simply with that technique. So check out his video about that. I thought it was really interesting. What do you think about it? We would love to hear what you think about any of these videos. Just provide a comment below, and let's hear what you think about the Y technique versus Menugian or NICS, or just shoving a really small valve into the annulus. I mean, is patient prosthesis mismatch really a thing? What do you think? Let us know in the comments below. So, upcoming events. If the AATS has given you the taste for more meetings, then there's lots coming up. In Dubai, there is a World Congress on Heart and Cardiovascular Diseases. It's just on the 19th of May. It is a hybrid event, so you can log on online, and it's all about novel progression through heart and cardiovascular research. There's lots of different areas. There's nuclear and molecular cardiology, pediatrics, cardiac nursing, and all sorts of different things. So check that out. There's links on our website. A really fantastic event is going to be held on the 23rd of May. It's the Hamburg Valve Repair course. It's a training course, and it's not only mitral but also aortic valve repair. This is held in collaboration with the University Hospital of Hamburg and also the University Hospital of Augsburg. And really, it's really never come of age in widespread use, aortic valve repair, has it? And we've talked about things like the Avalus valve, but here in this conference, you will be able to see the latest techniques for aortic valve repair as well as mitral, which really is of age and really is the default way to repair mitral regurgitation. So check that out. It should be really interesting. The final thing for thoracic surgeons amongst you is that EACTS hold regular case corners, and the next thoracic surgery case corner is on May the 25th. This is a session of complex thoracic cases. They'll give you the description of the patients, all the imaging, and a discussion together with the audience. It is fully virtual, so just register anytime and you can watch that online, and that's on May the 25th. Well, we're getting near the end of our podcast, but we always have two final sessions. The first one is entitled, Where's Diego? Diego, the world roving thoracic surgeon, world's most famous thoracic surgeon, and also has a foundation. Where is he this week? Well, last week he was in Kuwait. He flew to Costa Rica for just 24 hours, and there he performed bilateral segmentectomies, one on the left, one on the right, in a patient post-chemotherapy. He told us we didn't have time for surfing, much as he'd have liked, and he got back in a plane. Off he went to Madrid. I believe he did a few sympathectomies, and then he hopped straight over to Bucharest to start some uniportal robotics. So check out next week to see where Diego is next week. And finally, our honourable mention goes to Emily Farkas. Emily Farkas, as well as being one of our CTSNet editors, she's editor for Global Health, and being an absolutely wonderful, fantastic paediatric and adult cardiac surgeon. also is the most amazing mission proctor and mission surgeon. She actually was our mission proctor back in 2019. She came out when we did our first mission to Ghana, and she was absolutely fabulous, so smooth, so relaxed, and she's been on so many heart surgery missions all over the world. And I would just like to mention she went out to Ghana in March this year, and she performed Ghana's first hypothermic circulatory arrest case. A really young girl with a dilated aortic root going up into the head and neck vessels. She needed a Bentles, and so she performed a dynamic hypothermic circulatory arrest. And again, don't underestimate the difficulty. They have no platelets, no FFP. They generally get their blood off the patient the month before or off their relatives. You have very severe limitations what you can do. Coagulopathy is a nightmare, but the patient thankfully did really, really well, and we've got some beautiful photographs of that patient leaving hospital day 11. So honourable mention to you, Emily Farkas. You're a complete hero, and wonderful example to us all about how you should combine your daily work with some weeks maybe every year going out and helping those who are less fortunate than us in the West. So that's it. Thank you very much for watching to the end. I really am very grateful. So from all of us here at CTSNet and myself, Joel Dunning, thank you very much, and tune in next week for our CTSNet podcast.